everybody, and good morning. Welcome to episode 6 of OTalakayan. OTalakayan is PAOT's online interview program that tackles different issues and topics in OT practice and education. So for the month of May, our theme is Telehealth. Good morning, Kim.
Good morning, Lee. Good morning to all our viewers this Saturday morning. I think this is the first that it will be aired in the morning slot. But we promise you that today's episode will really be a very informative and interesting one. So last session, Ian discussed to us how telehealth may be delivered to children. So he covered minimum requirements on the part of the parents, technology, and activity selection for early childhood, middle childhood, and adolescence. So for today, it will be a very different area of practice. It will be hand therapy, and it's very interesting because for most of the time, we associate hand therapy with in-person service delivery. We will be doing splints, we will be giving physical agent modality. So I think most of the viewers are very curious, how is it going to be delivered in an online platform? But we're very fortunate that we are joined right now by our two esteemed resource persons. Maybe Lee, you can introduce them to our viewers.
Okay, so our first special guest for today's session is Kathleen Hunter. Kathleen has been practicing for 25 years. She's a graduate of the University of the Philippines. She's a certified hand therapist, and right now she's affiliated with Kaiser Permanente, Santa Clara, California. So, hi, Kathleen.
Hello.
Thanks for being with us today. How are you?
Thanks for having me back.
All right. Now, our second guest is Maria Crescida Bulalakaw. She's been practicing for 10 years. She's currently affiliated with the Western Sydney Local Health District, and she works as an occupational therapist at the Philippine General Hospital Department of Rehabilitation Medicine. Right now, she's 2 years into hand therapy and currently doing telehealth with 20 to 50% caseload. Hi, Kwek.
Hi, Lee.
Thank you for being with us today.
Yeah, thanks for having me too. You can call me Quick. That's fine.
Okay. Sige. I'm very sure our audience are excited to hear about how do we do hand therapy via telehealth. So, Kim?
Maybe we could start with this. For Kathleen and Quick, can you describe to us a typical hand therapy session, the overall process from referral, preparation to monitoring?
Hello, I have my slides, so we'll start with that so you don't get bored looking at me. So a typical hand therapy session, before the COVID, we were supposed to actually launch telehealth like maybe a couple of weeks before that. And then everything, when COVID happened, so full force telehealth, So when we actually get the referral from a doctor, because, where everything is online right now, we get the e-consult. So does anyone see the screen, the slides, the slide right now? It's okay. Mm-hmm. Yep. So we get the e-consult from the doctor. Under there is a diagnosis, and the other one, previous slide. We get the diagnosis, and then under comments, the doctor actually gives us if now we told them if they could do the inpatient versus like video visits, because typically we do the VCN2 where we do the videos first. So we got to see the patient, do a video, and then we can go from there and see how, our treatment, objectives. When we go to the objectives, I actually use this pretty cool stuff that I do, snipping tool. So because you can see from observation, like if I ask you to actually do a range of motion, I could put my goniometer, but it's not very, it's just more like an approximation. So I do a screenshot basically of the patients. I hold this position and I take a screenshot. I copy paste or I can crop and I do those things. It's pretty cool. And then I attach it to the SOAP notes for the patient. So I could actually like, from there also you can see the progress later on. The screen is actually big. I can't see the whole thing, the whole slides. So the next one is actually for intervention. When I do an eval, it's actually typically a 40-minute video visit for evaluation. And I could see if the patient needs to come into the clinic for follow-up, especially for post-ops. Right now, our post-ops are still, there's no elective surgeries, it's on hold. But when we see post-ops like flexor tendon, extensor tendon repairs, or some fractures, I have to see them in clinic because, or even mallet fingers, I actually have to see them in person so that I can fabricate the splint, because that seems to be the hardest for hand therapy. You can't really like do everything on video. But if I could teach them the exercises in the home program for during the visit as well. So what I typically do, we have this thing called online PT. So from their health Connect, this one I could choose a category. If a patient has decurve veins, I could do a template, attach it to their notes, and I could give them the access code from there. So we send a secure messaging to the patient that you know, they can see their exercises or the template that I sent them. Before, I actually do a sort of a handout like this. And I ask the patient, like, here, take a screenshot. So if they're savvy with their technical skills, they will take a picture and then they can remember that, you know. But we can also, now the online PT has the patient exercises, the templates for the things that I actually want them to have in like just one page. So that's actually pretty good right now. So they've been doing changes every day. So I think it's actually also called medbridge.com. So you can actually use that as well. But with Kaiser, it's already embedded in their Health Connect, their records. So after I do the online PT, so some of them I would say we're going to be following up the next 2 weeks or the following week, whether a video visit or also or in the clinic. And I schedule them for follow-up, and then I give them a reminder via text or email, so that way I can actually see them again.
Okay, thank you, Kathleen. How about in Australia, Quek? Is it the same process or different steps have to be done there?
Okay, so let me just share my screen. Okay, so from where I work, so I work at the Sydney Local Health District. Yeah, so it's a big hospital. Basically, it's a COVID referral hospital too. So we have COVID patients in the hospital, but then fortunately, our outpatient services for hand therapy isn't really close. But we did stop elective surgeries. We still do trauma clinics and other stuff. So I guess Kathleen basically did the whole thing, but basically kind of the same. We just have to follow like restrictions depending on what the government would tell us, like or the health minister. So it's depending on the restrictions. So right now we're kind of eased like to the restriction, but we're like on the level 2. So basically we don't see chronic patients because it's not the priority, mostly for stage 1, and we do face-to-face consults for most acute patients. So we just have like 4 or 5 different kind of what do you call this? categories for seeing patients. So like I mentioned, chronic conditions such as these on the screen, they're not a priority right now. So they are basically put on the wait list and then we'll see them later on when the restrictions are eased. So, and then this is like what Kathleen said, mallet fingers are very hard to manage via video. So basically what you do, or instruct them to tell you can't really do that. So this is like the guidelines that the RPA, it's like the other hospital in the Sydney main, like the city, CBD. So they did this prioritization guidelines. And basically, if you can see what only we need to see for face-to-face and what we need to see for regular telehealth and what we need to see ad hoc or we don't have to see and what we don't accept. So what the typical hand therapy session for us would be, so we normally do follow-ups, 30 minutes booking, 60 minutes for like new sessions, but we don't usually do initial session via telehealth. We only do it as follow-ups. So we do book them with 30 minutes booking. So our referral usually comes from, same as with Kathleen, we have an e-order or an e-referral. So for inpatients or outpatients, we get that. So we book them in following the prioritization guidelines. So no chronic follow-up patients not requiring face-to-face. And then our reception sends them the link, the VMR link, and SMS reminders 2 to 3 days prior, and then we await confirmation. And then during the session, so we open like a Zoom, but we have a different platform. We open it up earlier, and then they join in. So it's like a lock session. So they have to join and then we accept them. So because we use the same VMR, like we were given our own like platform, we have our own PIN. So basically it's the same one every time the patient sees us. So we lock it and then we just ask the patient to join once they're ready. And then we provide the treatment through audiovisual consult. So this is like just an example of what we email. So this is like we call our ones, the PEXIP. So they use a Google Chrome browser for that. And then, so I think one that I can add in addition to like what Kathleen said is that we have to gain informed consent. And that includes checking where the patient is and those present in the room. Also identifying where us hand therapists are working from, because some might be working from home, and in the room that you're doing the session, you have to tell them who else is in the room. So you just gotta let them know that I'm doing a session with 2 other therapists in the room, so to ensure privacy. But we're doing it like, again, it's not a loudspeaker. We do it on a headset. So they just mentioned that we gotta let them know about that. So so same with Kathleen, subjective reports. We asked them mostly what happened, how was the week, how did they go with their exercise, and then objective measurements is hard to do. We're trying to look for a tool, but same as with Kathleen, we try and like measure it actually on the screen. That's kind of weird. We ask them to hold it on the screen, and then you gotta hold it still, and then we try and put their goniometer on the screen. But yeah, I think we can take away that snipping tool.
Yeah, isn't it nice? Can you hear me?
Yeah.
The snipping tool, it's actually pretty cool. The only, you can crop it, and then I've done like, circle where the edema or the ganglion sits and something like that. So I think, and then I can crop it, but then so it's not big on the soap notes. It's actually very cool. I've learned that from the Northern California hand therapy. So maybe bring it to Australia, huh?
Yeah, cool. I'll let him know. So we do that, or we just basically we try and do like percentage. We just say like, oh, he can do like 50% hook face or 100% full face. We just try and approximate. We use that percentage. So yeah, this is for the next one. Anyway, so basically that's how we do the telehealth session. So we have like this PEXIP BMR, what they call this platform. So yeah.
Can I ask you what what's the patient's app that they're using? You said BM.
So they have this. It's called Pexip Infinity. So it's on the App Store or Google Store. So they download it, and then it's linked to Google Chrome. So you can't use Safari. It has to be Google Chrome or the app, which
Yeah.
is the Pexip. So yeah, I don't know exactly what it's. I think it's Skype related because it
Right.
has like a Skype business related something. So I think it's Skype-ish.
And it's just through your hospital, right? It's just specific to your hospital.
Yeah, yeah.
Yeah, I forgot to mention, ours is My Doctor Online, so it's an app, and then they just, it's a Kaiser web. So.
Ah, okay, yeah. So do you send links as well, or it's just like they have access to it or something?
Yeah, they actually send the links on how to go about like the front desk. Once they're scheduled, before they see us, they already actually have they open it. And because a lot of people prefer it on their laptop because it's a bigger screen. But I always tell them, I said, you know, and on your iPhone, it's actually better. But then some of them, I have issues. That's the thing with telehealth. One of the challenges is that you become sort of like a tech support because it's like, I can't see you, I can't hear you. I'm like, maybe refresh your screen or like log out and log back in. So, and then we cannot have them join like many minutes early because then, you know, you don't see me. So that's why I have to refresh. But yes, the patients do really get frustrated. And then some of them, it's like, so are you using a, which, you know, operating system? It's like Android. I'm like, I don't know, but I can ask because I don't have that. So that's one
Yeah.
of the challenges, right?
Same here. Especially older people get their hand condition, so you gotta tell them step by step. So yeah,
Right.
it's important to have like a really clear instruction when you send a link.
Mm-hmm. Okay, so thank you, Kathleen and Kwek, for giving us an overview about how hand therapy sessions are done, from referral, screening, perhaps assessment. You mentioned about using the camera, having the client position the hand in front and do the snipping tool. But I think the audience right now may be curious specific interventions like exercises, or are there manual therapy techniques that you do with the hand? How is it done via telehealth?
Who wants to go?
Uh, I know it was mine. Okay, so let me just share screen again. Oh no. Share screen. Okay. So sorry, not that good with tech stuff. Anyway, so how do we do the treatment, or how do we deliver intervention through the telehealth? So again, treatment is done like a usual session. So like you start with asking them how they were and such. And then basically it's more like a demonstration return demo. If we've seen them before for splinting, then they actually knows, like we prepped them already for what they're gonna expect in the next few weeks. Let's say you have a fracture on the, like a mild finger, where you had a fracture on the tip of your on the distal phalanx. So basically you tell them, oh, you need like full time on the splint for this week. So they kind of expect what they need to be doing. So when we see them, they're more like, oh, I kept it intact, I didn't remove it, I kept it dry during shower. So then we're like, if it's time to wean off the splint, we start like, we give them already the exercise sheets beforehand, and then we do demonstration and return demonstration. So if we do require like modalities, because if some of you are not familiar, when you get like a stiff finger and stuff like that, you would require like modalities like either hot packs, icing. So some of our clients already have like these wheat bags that we ask them, oh, if you could try putting on beforehand, or then you don't have to do this right now when we're doing the session, you can just do it, try it later on. But then the idea is this: we do it like 5 minutes to 10 minutes of that, and then you do your exercise. So basically we encourage them to use alternative stuff at home. And then for splints, we send them. So the good thing with that, like we can send them stuff through mail, So let's say they need like something like a tape, splint that are prefabricated, like any wrist splint, a soft one, Coban tape and stuff, or straps. We can just send it through the mail. They have like different sizes, but we sort of like give them basically three sizes or one size bigger and smaller, and then we just send it to them. We don't worry about like they're gonna bring it back or what. It's just we send it to them, and then so then when they get it through the mail and then we see them, we're like, oh, did you get the mail? And then can you try it on, put it on, and it's just how you use it and stuff and stuff. So we give them precautions on how to use it because we're not there to basically guide them. And yeah, we end the session with like booking for the next appointment. We decide if we need to see them face to face, or we do like another telehealth. So like if you look at the guidelines I showed you before, for flexor tendon, we need to see them weekly, and we can't do telehealth, so we do face to face. But then, like right later down the track, like 8 to 12 weeks, you can do face to telehealth with them. So yeah, and then just in addition, like Kathleen mentioned about using the My PT. So we have we're more like old. We use old software. It's called VH High. For some of you, you can search it, but then it's like an old one, but then it's still reliable because they give those exercises. Um, like the pictures are really clear and the instructions are clear. So we only need like the hand exercises anyway. So the VHI, I can't remember what exactly it stands for, but I think it's like visual home instruction, something like that. So you just send them, like you create a page where you pick all the exercise, and it just gives you all those, let's say 6 sets of exercise, like the tendon gliding and stuff. And then we share them on the screen, like what we're doing in Zoom. And then we email it using a secure account. Just can't use our own work email, and or we send them via post or mail. So, and then we also have like apps. There's a lot of apps you can download for hand therapy that shows you exercises. There's one hand therapy app for flexor tendon, so you can also use that. And then yeah, at the end we have to tell them, do you want to do a face-to-face, or you want to do an audio consult, or if it's not possible for you to do, like not all people have laptops and stuff, so they do have phone, but they struggle to use it sometimes, or the data, well, we have like data limited. And then so yeah, we offer phone consult, so it will be the same. We just like ask them how they wear. We don't straight away give exercises because we just check how they're going to see if they're regressing or not. So anyway, so yeah, and then we do a surveys at the end once we finish the, once there's discharge from service. So yeah.
Oh, the survey is more for parang feedback. Is it like feedback?
Yeah. We want to ask them like if they liked it. One patient actually said she doesn't like it at all. So
Okay.
yeah,
Thank
something like that.
you, Quick. Is it the same for Kathleen? Or
So I actually do have so where my laptop is right now, this is my setup. So I have my video, I have my monitor, so I have my tape. So my typical thing is like, so I do my observation, I do my questions, and then we go through the treatment intervention. So I go through like, okay, this is what you're gonna do, home program. This is your homework, because they retain it better when I say homework, especially for teachers. I actually have, I do the range of motion. We go through, I don't bombard them with many exercises, because you know what happens when you gave them like 4 or 5, whatever, more than that, they can only like, huh? So I go through the exercises with them. And then I do the modalities, so what they can do at home, contrast bath, heating, or something. And I go through some of the things that I say, okay, for acute or whatever. When they have pain, I do like my KT. I do like the kinesio tape. So it's very challenging. One of the challenges again, I would tape myself and I would show them on the screen how to put it on. And then, you know, because some of my the other colleagues, they actually can email you the YouTube video on how to put it on. But I go through it with them so that, you know, I know they will have questions later on, but I find that they don't bombard me, because they can email me and ask me questions after the visit. So I do it's more simplified. We go through, I repeat it, and then I go from step, you know, this is what you're gonna do first, you heat it up. Now, if I were to say, like today I had therapists as my patients. So I even was able to elicit how to do a Watson's chart test, you know, the Terry Thomas sign. So if you were to do ulnar to, and then do you hear a clunk? It's like, nope, I didn't. Like, well, but if I were to do it, I'm sure I'm gonna hear a clunk. So because it's their scaphoid lunate that I'm actually looking into. So I can sometimes have them palpate, you know, for CTS, you can say, okay, you could do this, and then where is the, that's doable, right? But for taping, like for a carpal tunnel, it's like, so I really have to say, definitely it's doable for some, but I sort of, as a therapist, we're very skilled in looking at like, hey, if you give this to a patient, this will be understood, or like, no, they're going to be so going to be hard to follow. Like for RSIs, I actually do the movements with them, so then I could even like stretch myself, because right now I have, Silicon Valley here in Santa Clara and San Jose, we have a lot of techies. So I go through the exercises with them, the stretches, 4-5, and then I can go to my to online PT, and then I can email them the access code, the exercises. Some of them, obviously, they can't really like just take a screenshot or remember what I said. So then that's when I do online PT. I even had one of our surgeons because he's so nice. When he sees a patient, he wants to give them the exercises. So we actually taught him how to go access online PT and then give it to the patient as their, as part of their, from the messages that we can send. So I think it's great that I know we can't do it all, especially for, let's say, fracture, for them to actually push themselves. It's like, if you have pain, I don't really care. So, but it's really hard for you to do it to yourself, right? It's like, okay, you could do a downer. So that's when I do assess that next week I'm at the clinic. I'm in the clinic 1 day a week. So for those like arthroplasty, it's really not progressing. So then I have to do more manual work on those. That's when I actually have them come into the clinic, and the front desk will give them a level 1 mask, and I get a level 2, and then I could see them face to face.
Thank you very
Okay,
much.
thank you. So our speakers really gave us some tips as to how we could still monitor our clients even if we have prescribed them strategies through online platforms. So I think for the next question, how about clients that are recommended for splinting? So what is the typical protocol? Is it prefabricated all the time? Do we need to Do we need to visit them? Do they need to come to the facility first? So how do we go about splinting?
So I guess I can answer that first, no? So for splinting, when I have a flexor tendon or extensor tendon repair, we're trying to kind of like make sure that they booked in the clinic for their first visit. I think we're working on that. So, even the doctor, when they say inpatient, in-clinic visit, so they're specified. And if they say splinting, I don't think sometimes the front desk gets it. So they might book it as a VCN too. So first visit, I see them in the clinic, and then I can follow up in the video. If it didn't work, like I have a mallet, for example, so I have this 40, he used up all my 40-minute video. So many questions for a mallet. Some patients are just sort of challenging that way. Then I have to book him the following day so I can make his mallet splint, because it has to fit right. It has to be done properly, because they're going to wear that for 6 weeks full time. But the only thing when we actually do like in a video, you can evaluate if the patient can be seen or in person, so then you can schedule them as such. Now, when we do see them in the clinic, because of COVID precautions right now, infection control told us to actually, we make sure patient washes they wash their hands first. Well, if you have a suture or something, you probably just do your best to kind of like sanitize the hand and then apply the splint, right? You can still sort of like dip it, you know, just the edges to actually adjust it. I think that's still allowed. Otherwise, you wipe the splint that you fabricated before dipping, because initially they said you have to change the water in between patients. Like, no, that's not going to work, because that's, you know, you know how long it takes. But the scraps, for example, we have extra, because here, I don't know, you guys probably save it. We do too. So as long as it's like sanitized with those sani wipes, then we can actually use it for another patient if we were to use that. So that's something new for our infection control. I don't know if you guys have a different thing in Australia right now. So, but that's what we're supposed to actually do. So I have pediatrics actually coming in. So if you're not very, we can wait a few more weeks because we don't know how exactly everything will open up. We actually do sort of triage that if that is really important to be seen right now, especially for growing kids when their thumbs are adducted. So I can pick and choose and see if they're really necessary to be seen sooner than later.
Okay, thank you, Kathleen. How about in Australia?
Okay, so I think what I can just add, yeah. So we do splinting face to face, mainly for, so we have this like plastics clinic where you usually see trauma patients, acute ones. So it's ongoing. Only elective surgeries are stopped. So we basically see those from AD who get referred to plastic surgeons and then referred to us. So they run this clinic, and then we see those patients that come down to us to have splinted. So mainly that's the first session that we get, and then the rest is like follow up. So yeah, so we see them. We only see patients face to face that are splinting, where assessment not appropriate through audiovisual, and then if it meets the criteria for acute or subacute. And then we see inpatients definitely face to face, and then we have guidelines set by our manager. So I'll just put out on the next slide. So for outpatients, there's like a screening plan for OT outpatient in response to the COVID. So this is a property of the Southeastern Sydney anyway, but for our interest group, we have this shared between us. So it's just before attendance, they have this like 2 questions now. Just, have you traveled overseas in the last 14 days, which I don't think anyone have traveled, but anyway, have you been in close contact with any confirmed case? Just like 2 important ones for us. And then if yes or no, it prompts us to do like, if the no questions, then we proceed to the session. And if this is like yes, we have like this help line that they call and stuff. But yeah, it's more perception. And then so during attendance, so even if like, let's say they said no to everything during outpatient attendance, so we also ask them again basically to say if they're have any contact, awaiting results for COVID, etc., etc. So, and yeah, so when they're all cleared, so if the answer is yes to some of them, we don't see them. If the answer is no, then we can proceed to see them. So we just have these general guidelines with face-to-face contact. Basically, when you see a patient for splinting. So again, screen them carefully before session. You take appropriate precautions, and you do distancing in treatment spaces. And we have this Perspex screen. I think some other countries doing hand therapy adopted the same one. So they have this screen in the treatment table. So then you kind of like protected. I know that COVID is like, it could be, how do you say? They say it's a heavy particle. So then when the patients cough in, it usually drops down to like the surfaces. So it's not necessarily like airborne, they breathe and then it goes. So they say it's more of like a heavy particle, so it would stick to surfaces. So we have this like board Perspex screen and a treatment table that we use. I'll show you in a bit. And then we clean hospital equipment between each patient. So with the splinting pan, definitely you can't change the water, but then you can like use, let's say it's a small finger splint, you can use like hot water on a tub and then just throw everything. So that would be one thing maybe you can do instead of using the whole how do you call this, the splinting pan. So anyway, scissors, dressing trolleys, you have to clean them. So the suggested one, according to the infection control, you have to clean it with neutral detergent wipe. You have to wipe vigorously because the mechanical action is important, and then dry it off with a ready wipe. So it's just normal like paper towel in for us, and yeah, paper towel or ready wipe, and then you clean it with ice wipes or alcohol, which should be 70% isopropyl, and should be allowed to dry. So basically, we do that after sessions. Before we see another patient, and then so this is what I'm telling you. Excuse the clutter in our hand therapy room, but so it's not like a big room. So we have like 4 treatment tables. So the one here at the very back most, it's like our telehealth corner. So we don't use it for face to face. We just do the video on that corner. So then there's like no other people in the background. But this is like the can't pronounce, perspex screen. So it's like an acrylic made of screen that has like, yeah, so it's clear, and then you have like an opening here where the patients put their hand. Sorry, I don't know if you can see the pointer, but anyway, so there's like an opening underneath, and we have a paper towel on the table. So then we just throw it away. We don't have to wipe that. So I know we heard every hospital is running out of the alcohol rubs and the what do you call the basically the cleaning stuff. So we're running out of wipes, so we have to conserve it as well. So rather than wiping the table, you just throw away those disposable stuff. And for splinting, yeah, we still use the splinting pan, but we try not like double dip. So if you put in our patient, just cut everything, make sure you either use the heat gun or dry heat, so then you can fix it up and then strap. So we try to do as much as we can, as quickly as we can, so then we don't really see the patient for like longer. So this is like a more close-up view. So we don't use the paraffin stuff anymore because that's not how do you say, yeah, not hygienic. So because we can't change the paraffin wax. So for everyone just who's not familiar, it's like the candle wax that you put your hand in. So then in place for hot packs, you use that for smaller joints. So you dip your hand there, and then most of you knows that anyway. But yeah, we don't use it because it's not hygienic. And then yeah, so we use appropriate PPE. So like I think Kathleen said, level 1, level 2. Weirdly, in Australia, we don't use face mask. It's not encouraged to use. Well, patients do. Patients do wear face masks, but so we save the face mask for airborne precaution patients. And if you're doing like the really intense session with the patient, like prolonged or anything that would require the patient to really how do you say it, for other procedure, then you do the level 2, which is the N95. So basically for general precaution, we have this like level 4 and level 5. So 4 is just you wear the face mask, you wear the no hat, you wear the goggles, and you have your gown, and then you have your gloves. So for the 5, you put the hat in addition, and you use N95. So it just depends, I think, on whatever hospital. But so we just follow appropriate PPEs or the infection control safety stuff. So and then we need approval from the department manager for us to see any COVID positive or suspected patients, which that's for inpatient. We still have hand therapy patients that are referred as inpatient, so we don't see them unless our manager approves of it. And then we reduce the time the patient is seen. So we try and do the 60 minutes to like down to 20 or 30 minutes. And we have like the HPI questions done over the phone, which we can do on another day. So yeah, that's basically what we do for face-to-face splinting sessions.
That's good. Can I ask you, when you're splinting, because do you like the plexiglass? Because you're just one way, you can't really go.
Yeah. It's uncomfortable, but they gotta do like that. Like they gotta go over
You gotta go
from the land down.
We gotta go over the other side. So we just gotta do what we gotta do.
No, but they don't, because with me, I actually have the mask and then the patient mask, and then I actually have to form it because I find like we're very close in contact with the patient. So a splint
Yeah.
is definitely challenging for us. So I guess for COVID patients, you know, positive, then it's definitely you have to do the level 4, level 5
Yeah.
with your goggles and everything, like my New York colleague there. But I just find, because I was about to order or ask my supervisor to order this plexiglass, but then our table is like narrower than yours, which
Yeah.
low, you know, but we actually go to the side of the patient. So I think that's probably not in our best interest. So I don't know, but if it sounds like it works for you guys.
Yeah, I think it's just well, it's precautionary measures. I guess the thing is we won't really we try as much as possible see patients that are screened properly, like that not already having any symptoms. So it's just a secondary precaution, but it is hard.
Right.
They did like a work health and safety audit to it. They say, oh, won't it be like it's gonna fall towards the patient? So it's actually velcroed to the table, so it won't like
Okay.
move or stuff. So it was velcroed on the table. So
And so
then
you're
cleaning.
and then you're so who cleans that? Do you have an aide who cleans the table?
Yeah. Well, after session, it's us who do it. So, but at the end of the day, it's just the aide who do the cleaning for the whole board. Yeah, it gets a bit cloudy, but doesn't matter.
Yeah, we have a list of people coming into the clinic. So when I have somebody from plastics walk in, it's like, how did that patient end up like? They're kind of like, whoa, Kathleen, well, I added one because it's a call from upstairs, you know. But the Sani wipes were very limited in Sani wipes. So the aide, he has to clean the table and the chair, and then we use towels. So we really throw the towel one use only. So.
Are I call my question, that got me curious. Is the plexi, what's it called it again?
Plexiglass.
Oh, so it's sturdy. It's a hard
It's a
glass.
hard
glass.
Yeah.
Okay.
It's like acrylic. You know the one that they made in the Philippines, like the cover for intubation, extubation. I think it's the same material.
Acrylic, I see. All right.
Yeah.
Oh, okay. So how about documentation? How is documentation done?
So I think it's my. I'm gonna go first for this one. Sorry.
Do you want me to start so you can take a breather?
Yeah, can you do this?
Okay. So my niece Arden, she has my slides. Can we do the documenting? She's very good. She actually did this, all hers, her PowerPoint. I'm not very good at that. So the next slide, I'll show you what I do. So this is just the objective measurement. You see my nice snipping tool, and I can actually draw. I can choose what color I want, but I actually chose blue. I like blue for some reason. So this one right here, so I have the observation, edema, resisted test. So I do all those things. Resisted test, then you could just show the patient how to actually do it. Like I said, you can kind of like think if your patient's like good and reliable, and you could see it in the screen. Palpation, I can ask the patient to, I cannot see, palpate, or if there's any tenderness. So for him, I suspect he has some of is this a TFCC problem here? Nope, no tenderness on the ulnar wrist or TFCC, so that's good, but I just noticed that it's just a bit bigger. Usually I would take a screenshot of both wrists so then I could see what's more prominent, but for me, because I do this quite a bit, I can tell that there's a discrepancy on the ulnar styloid right there. The next slide, or then I have the exercises. I instructed on what exercises I told the patient. The next one is next slide over, please. Treatment procedures. I just put video visit because I'm not sure with Australia if you're doing we can't bill. So I know the patients are still paying for their premiums and stuff, but we just say video visit, or I don't put OT evaluation because we have different codes for if you put a manual therapy and stuff. So we just basically for now, I don't know how we get reimbursed because telehealth is it just happens so quickly. So we just put video visit, how many minutes. For evals, we have 40, like I said. And then I don't even put Therax, so I just do the total time. For assessment, I just put, the diagnosis, signs, symptoms, what might be the problem, just like your typical. And then after that, I have my goals. A few goals right there, and you have how many weeks. And then for my plan of care, I usually say if I am going to see this patient via video visit, when that might be. And I mean, I don't go over like what exactly I'm going to do the next visit, but, like recheck motion, definitely, and then edema management there and see plan of care. So it's actually a short and sweet, but I do like the fact that for my observation, I actually can, before I would really like measure, and then I have my, what do you call this? The table. And what I do like is I couldn't show it here because I can't copy and paste the pictures. So from, I would say previously down below my notes, and the second time or the third time I see a patient, I would put the other picture. So if they increase wrist flexion or wrist extension, that's their picture. I just make it like a little bit smaller. So let's go back to another screen. I could probably show you. So like, for example, this patient right here, so he's doing an index finger, he had a laceration here. So this is his hook fist currently, and then actively he's able to do that right now. So below that is the previous picture that he had, or the numbers. Like if I saw him in clinic, then I will have the numeric. So because really it's really hard to quantify range of motion when you're like this, it's like your angle is you can guesstimate. So the surgeons do what they do. They have, I don't know where they find it in the keyboard, like that approximate. So I just write APPRO and they put the approximate like 30-35 degrees versus like with me, I think in the Northern California hand therapists, we actually do that. Now, I know we're all occupational therapists, right? So when we do range of motion, that's subjective, but we also have to kind of like think functional, because when we have PTs, I know we have PTs, OTs in the audience. We kind of like need to do some functional. Are you able to actually do this? Especially for a Medicare patient, 65 and above. I think it's nice to actually quantify in your what type of, can I hold this? Can I hold a marker? Or can I grip something like the cylindrical? So I think that's what I need to kind of like add to my objective, is like some of my functional measurement as well.
Okay, how about you, Kwek?
Okay, yeah. So mine is just like really brief for documentation. So we use so we have this everything is an electronic medical record. So we use like a power chart. So we put everything in there. So basically just soap notes. So I think the difference with just a normal face-to-face session through a video or audio video consult is that it's more heavy on subjective reports and clinical observation. So and then Kathleen's one, because I think they're more like third-party payers. So in Australia, because I'm in a public hospital, so we're more like doing public. So we don't have to put all the goals and stuff because it's like a public one. So so we usually just do soap notes. So we state the session done either via telehealth or face to face, and then just any photo uploaded we put as confidential and consented by patient. So just maybe that's one that we can add. And range of motion reading. So yeah, that approximate. So you have to use that every time, or we use like near reasonable range or we use like near normal or within functional limits if we find like it's okay, or slightly limited. So we kind of like describe it. We can't use like exact measurements. If we say like, oh, patient complaints like subjective tender on palpation, or it's like swollen, minimal, moderate swelling. If we look at the scar, we just describe appears raised, um, and then stuff like that. And then we use percentage. So we basically like shortcut it to like, oh, he's doing 50% full fist now compared to last week. We just like around 25%. We don't do in between. Only it's like 25, 50, 75, and 100. And then we just put the booking as either next session would be a video, next session will be an audio video, or it's a face-to-face consult. And we maybe the plan that we do is like we say, oh, for the next 2 weeks, patients will be on a video consult for telehealth. Patients will be weekly telehealth consult, and then we can be discharged in the next, aim for discharge on the like the 4th week. Or if it's like like not really chronic, but let's say complications arise. Let's say the patient is already healing like 5 to 6 weeks down the track of a fracture of a something, a hand bone. We can say patient can present face to face on the next session because let's say we need to do like a correction sprint or something like that. But yeah, we just use normal soft notes, and we make sure that we don't put exact measurements because we can't do that on the video consult. Yeah.
Okay, thank you. So for our last question for today's episode, given the restrictions, the limitations that we have right now in the Philippines, how can all these recommendations be applied here in our country? Can you give suggestions or any recommendations for the Filipino OTs who are practicing hand therapy? Kathleen or correct?
Siguro dagdagan ko kay Kim, no, considering na dito, internet is not very fast. Some patients might not even have the access to a smartphone or a laptop. So I could just imagine paano pag hand therapy na call lang. No?
Right. Oh, I can answer that. Sorry, I was muted earlier. I was saying that give it to Chris first. The challenges of having an internet connection, yeah, I understand that. Because when I call my mom on Viber in Laguna, I'm like, where are you? It's like, I can't see you. Can you hear me? And so we can't even do a 3-way. So I think a good connection. So one of the requirements is to have a device, whether it's a laptop, iPad, all the Macs, non-Macs, and everything. You have to have that. The second is internet connection. Even for us, you know, we already have people who have like really, like I put in like a Nest Wi-Fi, Google Nest right here. Oh, I know how to install that. No, actually I had help. But if you do Wi-Fi versus like a non-Wi-Fi, sometimes it increases the connection. That's another one. But then there's also the app. It gets to have a lower bandwidth. When I notice this when it's kind of like rush hour, you know, like when there's traffic, everybody's like Zoom, all the kids online. So between 11 to whatever, that's actually, I tell the patient, so yes, it can get frustrating. So those are, it's not, so those, once you get, you pass those devices, internet, now what do we do? What is like for the Philippine therapist to actually do? You just have to be creative. I mean, you know, you have your objective measurement, like I told you, like you do your subjective, listen to the patient first. We can't jump in. You know how like when we're in the clinic, like we're already touching. It's like, stop touching, halt, and then listen to what the patient's saying. Because a lot of people do share, but like you're just in your back of your mind, you have a time limit, like I'll allow you to talk, but then what seems to be the problem? So you direct it. So they're more at ease. I mean, they're already at ease because they're at home. Like with me, I'm working from home a few days a week. So, and then the next one, then you can actually like one of the tips that I said, you can give a few exercises, so you narrow it down to, you're really good. Like for pediatrics, I heard it's a 2-hour session. Yeah, that's gonna cost you that much. So 2 hours, for us it's 40 minutes. So it has to be concise, it has to be short and sweet, and then you're not gonna bombard with many questions because it's already, like a systematic approach, I would say. And then as you do this more often, like it's not very actually hard to do. It's just that if you are able to do it, yes, that's good. We forgot something later. It's like this is our new normal. Before, we're actually normal in terms of like, I know what to do. I can assess you there. But if you assess it objectively, I know you can't palpate, so you will have some sort of like a difference. Like, because the doctors do send it to us too, and then they do their best from a video perspective. What might this person have? Well, when you send it to a specialist like us, we will tell you if it's a radial or the ulnar collateral ligament, and is this a A1 pulley? So we are narrowing it down to, because we've seen those cases. So there's the skill set we involve as well. I think those are probably some of the tips, not just like, and then you have to be creative what they can use at home. Well, you don't have a splint, you can't see me. Is there a stick, a popsicle stick, and like a tape? So we have to actually be a bit more creative, because I think that's doable, I think, right?
Great, thank you. How about Kwek?
I'll make it just short and brief. I think telehealth was meant to be, before this COVID thing, it was meant to be done, I think, prior, like for people who can't go to the hospital and stuff. So I think there might be like resources really that patients can use to and clinicians to use to do telehealth. It's just like what Kathleen said. It depends how creative they can be, and again, they gotta be flexible with regards to this kind of setup. So yeah, you just gotta trial different methods and see what works. And I guess the thing is prioritize what you need to say and actually not say, and then also utilize family members, like those the son's daughter or whoever in the house who knows how to do the technical stuff and work it out for the patient, and then that other family member can help the patient to set it up, and then it's just the patient doing the session with the therapist like a normal. So yeah, gotta do whatever we can.
Okay, those are helpful. Thank you very much for your recommendations. Okay, we have some questions from the audience. Directed to both of you. Do you adjust the time set for the goals part, since you don't really see the clients face to face?
I think for me, because we set like 30 minutes per follow up. So basically, with telehealth, we basically do like, I never finish 30 minutes. It's mostly like 20 minutes or so. So I think, yes, we do adjust, because like what Kathleen said, if you actually give them a lot of stuff, like I don't think 1 hour would be over the video would be too much. Like for hand therapy, we have like clear set goals for a particular condition. So once you actually gave them what is needed for that week period, then that's enough for me. So I normally do less than 30 minutes.
Okay, how about Kathleen?
So you mean like goals for how many weeks you're setting this, or just for the visit?
No, maybe on both. On both.
For the adjusting the visits, like that 40 minutes, because if I don't have a full schedule, which I'm finding we're getting busier now, I think I can make it be done like in 40. And then that's why I said, I think one of the skills that would be good is that you know how to start, let the patient talk, then you do your assessment, and then it's you again to tell them what they should be doing as home program, and then you close it with a follow-up. Unless marami silang tanong sometimes. And then, so I think typically we can do it like in that amount of time. they like the ability that I can follow up in like a week or two. If it's not really acute or anything, the 2 weeks is enough. And then they like that. And then I send them a reminder. As far as goals, how do I adjust the goals? I mean, for Medicare, we have a recertification of the goals. You have to do it within like 12 weeks or 3 months. But for us, it's like as we go along. I usually put like, it's safe to say, because I've seen many caseloads now, like 6 weeks is fine, 8 weeks is that for a typical, it's based on your protocols as well.
Okay.
Okay, now for the last question, how is it with pediatric clients? Are the parents typically involved during a telehealth session? Kathleen or Kwek?
So I think, yes, definitely, like, especially for a baby, that's not gonna be happening to answer. So the mom has to be involved. I don't see a lot of pediatrics, but I do see them. So the mom or dad, they're actually like, oh, don't wake up the baby, just lift the blanket and actually just like see what the thumb looks like, and then that's it. And then we talk. So then, and then I assess from the best of my ability what it looks like. And then I can, of course, you can reassure them. It's like, oh, I hear it from the background. The husband would say, it's like, so what? Like, she's only gonna do this, and like, is this not gonna be surgery? So they have a few questions. So yes, you can answer them, and you can sort of like, I think as a provider, they do think you know what you're doing. So when you say, I'm gonna see you in the clinic so and so, or I'm not gonna, it's very hard for me to kind of like say no to bringing you into the clinic and then having to fabricate a splint. But like, for example, I had one patient who's already like, I saw in the video, I saw in the clinic, I only did one finger. Oh, during COVID, we forgot to say this. When you're making a splint, when you're masked, it's actually hard to breathe, right? And it's hard sometimes, because this is your new normal. It's kind of like hard to think. So it takes you a bit longer in your processes, where you normally do this like boom, boom, boom. So if I were to do just like one thumb, and whether it's not like I'm making an excuse, so I will try the one thumb first, we'll make the other split, because having to make them both at the same time, it's gonna be a long, more than 40 minutes, kind of like with my tendon repairs. But I would say for that, I will have the next visit, and we can actually but try this first.
Yeah, just for me, I don't see pediatric hand patients, so mostly teenagers, yeah, but they can do it. So not much experience with pediatrics doing hand therapy via telehealth.
Okay, so I think we still have a follow-up question for Kathleen. In your hospital or the place where you work in, do they give you a format for documentation, or do you use your own format?
Yes, I actually, so we have smart phrases, and under there we have, for, let's say, we're actually doing this right now. We have a format for decurvain, CTS, and I specifically .kh, that's my phrase. And then we have all the, we have like the asterisk, and so I just go tab, tab, tab on those, and then I can just answer. What I find is that, and of course you change it to video visit. We've been doing that even before. We have templates. Even for the after visit, I do have a template for your like, hello, it was a pleasure to see you on our video, thank you. So I have a template for that. It makes it a lot easier. Yes, we do have that.
Okay, so thank you to our two esteemed resource persons. Surely our viewers have learned a lot. They have learned your perspectives, your practices there. And just like what you have mentioned, we need to contextualize it here in our Philippine setting. We need to be creative. We need to be flexible. But I think this episode really gives us that assurance that even if conventionally we haven't really thought of hand therapy being delivered in telehealth, the Filipino OTs now would have that assurance or that idea that indeed it can be done. However, there are a lot of requirements, a lot of considerations that need to be put into consideration too. So thank you. So Lee, maybe you could advertise our next episode to our viewers.
All right. Before that, again, thank you very much, Kathleen and Kwek. We're happy that you join us from other parts of the world. Okay, no? International na ang ating mga guests. Maybe, sino kaya ang ating mga next international guests, no? So, I'm sharing my screen right now so you could see that on Monday and Tuesday, we won't have a live episode because we've received many requests na mag-rerun nung mga episodes natin in the past. So we've decided to rerun episodes 1 to 6. We'll make it available for viewing of members. So if you are a lifetime, regular, and student member, you could go to our YouTube channel. It's uploaded there. All you need to do is to log in using the email address that you used when you applied for membership or when you renewed your membership. So we are sharing those videos to that email account of yours for private viewing. Tandaan, it's only Monday and Tuesday. So after these dates, these videos will not be available anymore. And because this is a member privilege, so it's for private viewing. Episodes 1 to 6, so it includes what we had just now. Okay? Yeah. So that's it. So, okay, parang nawala yung ating dalawang...
Thank you. Am
Hello.
I?
Akala ko iniwan nyo na kami.
Thank you.
We're still here.
Thank you, Lee. And this is me. Stay healthy, everyone from Machu Picchu last year.
Wow.
Again.
Thank you, Kathleen, again, and thank you, Kwek, for being
Yeah.
with us. It's late in your place. Thank you. And Kim?
Yes, thank you. And we hope you could still participate and join our next telehealth episodes.